This topic is thrombocytopenia. The term thrombocytopenia refers to a low serum platelet count. Platelets are exceptionally important when it comes to forming blood clots within and outside the body. With low platelet levels, the client is at higher risk for hemorrhage and can develop life-threatening bleeding if levels are too low. Thrombocytopenia can result from a decrease in the production of platelets, an increase in the destruction of platelets, or from increased platelet aggregation or clot formation within the body. A normal platelet level in most clients is going to be higher than 150,000 platelets per microliter of blood, or 150 times 10 to the 9th per liter. While some form of uncontrolled bleeding may occur when platelet count is under 150,000, significant bleeding from trauma or injury can result when platelet count is less than 50,000, and spontaneous bleeding may happen when platelet count is less than 20,000. If a client has significant bruising or visible signs of trauma, monitoring the platelet count is essential to determine whether or not the client's body will be able to form clots spontaneously to control bleeding. Thrombocytopenia can develop from a number of different sources, including certain medications, infections, malignancies, and disease processes. Two examples of medications that can cause thrombocytopenia include heparin and chemotherapy. Heparin can lead to heparin-induced thrombocytopenia, which we will talk about on the next slide. Chemotherapy inhibits production of many different types of blood cells and components within the bone marrow. This can lead to anemia and neutropenia, as well as thrombocytopenia due to decreased platelet production. Infections, such as HIV and hepatitis C, can lead to stimulation of the immune system and creation of autoantibodies against platelets. This leads to platelet destruction. Thrombocytopenia can be caused by hematologic or blood-based cancers. The growth of certain leukemias and lymphomas within the bone marrow can prevent production of normal platelets. Immune thrombocytopenic purpura, or ITP, and thrombotic thrombocytopenic purpura, or TTP, lead to thrombocytopenia in different ways, which we will look at on the next slide. And disseminated intravascular coagulation, which can happen from sepsis, tissue injury, and other types of inflammation, results in massive platelet consumption as clotting takes place in blood vessels throughout the body. This leads to significantly low platelet levels and can contribute to spontaneous bleeding. Let's further discuss the types of thrombocytopenias. Now, these are all either due to antibody formation, which can cause destruction of platelets, or clot formation, causing platelet consumption through aggregation. ITP is an autoimmune condition that occurs in response to certain disease processes, especially viral infections. When certain viruses enter into the body, this causes an immune response that generates autoantibodies against platelets. These antibodies will bind to and cause the destruction of platelets, leading to decreased platelet counts. TTP is another type of thrombocytopenia that is uncommon. While TTP has several causes, TTP occurs when platelets aggregate into microclots throughout the body. These clots get deposited into the brain and kidneys, causing neurologic dysfunction and renal dysfunction. Heparin-induced thrombocytopenia occurs from exposure to heparin. For some clients, exposure to heparin can result in an immune reaction that leads to the creation of an autoantibody that leads to platelet aggregation. The binding of these platelets results in a decrease of greater than or equal to 50% of platelets from the baseline. Platelet aggregation leads to thrombosis or blood clot formation within the arteries and veins. With certain types of thrombocytopenia, the client may be asymptomatic and not even know that they have a low platelet level unless screened by a healthcare provider. The main manifestations of thrombocytopenia are associated with bleeding due to a lack of platelets and platelet adhesion. These include petechiae, or small pinpoint hemorrhages on the skin, purpura, which are non-blanchable purple patches on the skin. The image on this slide shows a depiction of purpura. Hemorrhage from mucosal sites, which may include bleeding gums, epistaxis, also known as nosebleeds, and hematuria. And prolonged bleeding after invasive procedures may occur, such as from intramuscular injections or even venipuncture. To diagnose thrombocytopenia, the healthcare provider will look at certain laboratory studies, including a complete blood count to assess platelet levels, and coagulation studies to assess for increased bleeding time, PT, and APTT levels. If necessary, the healthcare provider may perform a bone marrow biopsy to assess for the presence of certain malignancies that may contribute to the development of thrombocytopenia. To manage or correct thrombocytopenia, interventions will focus on treating the underlying cause. Platelet transfusion may be appropriate in certain situations, but not all, as administration of platelets in TTP and HIT or heparin-induced thrombocytopenia can worsen clot formation. For some clients, they may simply need to stop certain medications, which includes heparin and chemotherapy like we discussed earlier, as well as other medications including sulfonamides and statins. If the client has an infection, we should treat the infection. This includes the use of antiretroviral therapy in clients with HIV, antiviral therapy in clients with hepatitis C, and antibiotics for certain blood infections. For ITP, we should anticipate administration of corticosteroids to reduce the body's autoimmune response, which will decrease the destruction of platelets. For TTP, the use of plasmapheresis or plasma exchange can remove aggregated platelets and blood clots from the blood vessels. Now with plasmapheresis, we should anticipate administration of corticosteroids to suppress the client's immune response. And for HIT, we should first stop heparin to prevent autoantibody formation. After heparin has been stopped, the client will need to continue anticoagulation with direct thrombin inhibitors, such as argatroban, to prevent thrombotic events from occurring. For clients with thrombocytopenia, the nurse should provide education about preventing uncontrolled bleeding. This includes using a soft bristle toothbrush, gentle flossing, and non-alcoholic mouthwash to prevent trauma to the oral cavity, avoiding forceful blowing of the nose, which can burst nasal capillaries, keeping track of the number of pads used during the menstrual cycle and reporting an abnormally high number to the healthcare provider, avoiding activities that may cause trauma, including high-intensity or impact sports, avoiding tweezing eyebrows or hair from other parts of the body, using an electric razor instead of a safety or straight razor, which are more likely to cut the skin, taking acetaminophen instead of NSAIDs, such as aspirin or ibuprofen, for pain relief, using stool softeners and laxatives to prevent straining during defecation, which increases the risk for hemorrhoids, and wearing sturdy shoes with firm soles to prevent trauma and injury to the feet. Clients should avoid intramuscular injections to prevent blood vessel injury and excessive bruising, and should also avoid suppository routes for medications, as this type of administration may cause mucosal injury. If a subcutaneous injection is unavoidable, the nurse should use the smallest gauge needle possible to reduce tissue trauma, apply direct pressure for at least 5 to 10 minutes after injection to control bleeding, and apply an ice pack to the site to promote vasoconstriction and decrease blood flow following injection administration.